Welcome to the Hospital Medicine Unplugged podcast. Today we are looking at a topic that, quite frankly, used to be considered a geographic niche in medical education, but has rapidly become a global necessity for the modern clinician.
It really has.
We are talking about thalassemias.
It's a massive topic. And when we talk about thalassemias, we are referring to a whole group of inherited hemoglobinopathies.
Well, inherited.
And they're all defined by one specific failure. The reduced or, in some cases, completely absent production of globin chains.
I want to pause on that definition immediately because I think for a lot of us in hospital medicine, we lump hemoglobinopathy into one mental bucket.
Yes.
You know, we think sickle cell, we think thalassemia, and we kind of move on. But there is a fundamental distinction in the mechanics here.
There is.
Sickle cell is a qualitative defect. The body is making the wrong kind of protein. The hemoglobin molecule itself is shaped incorrectly. Thalassemia is different?
It is entirely different. You've hit on the most important point right at the start. Thalassemia is a quantitative defect.
A production problem.
Exactly. The body has the correct blueprints for the hemoglobin structure. It knows how to build a perfect alpha chain or a perfect beta chain. The problem is the assembly line. It simply cannot produce enough of them.
And because hemoglobin is a tetramer, it requires this very specific balanced structure. When you stop making enough of one part, you don't just get less hemoglobin.
No, you get a catastrophic imbalance. And that imbalance is the real root of the disease.
That imbalance is really the villain of the story today. It's the root of all the pathology we are going to discuss.
It truly is.
But before we get into the molecular mechanics and the bedside management, we have to appreciate the sheer scale of this. I was looking at the epidemiological data, and these are the most common monogenic disorders in the world.
The numbers are absolutely staggering.
Yeah.
If you look at the global prevalence data, approximately 5% of the entire global population carries an α-thalassemia allele.
5%. That's 1 in 20 people on the planet.
1 in 20. And about 1.5% carries a beta-thalassemia allele. So combined, it's an enormous number of people walking around with these genes.
Which translates to a massive clinical burden. The 2021 data showed something like 1.3 million clinically significant cases worldwide.
Right, and that's not even counting the carriers. And every year, about 40,000 infants are born with a form of thalassemia significant enough to require transfusion dependence from the very start of life.
Historically, we've associated this with very specific regions. The name itself, thalassemia, comes from the Greek thalassa for sea and haima for blood.
It's the sea blood disease.
Right, pointing to the Mediterranean basin. And for a long time, at least in Western medical education, that was the primary association. You see a patient with a Greek or Italian surname, you think, thalassemia.
That was the classic board question, wasn't it?
Absolutely, but the map is much, much wider than the Mediterranean coast.
It is. We see a high prevalence across what we call the thalassemia belt, which is essentially a tropical belt. It extends from sub-Saharan Africa through the Mediterranean, into the Middle East, the Indian subcontinent, and all the way through Southeast Asia.
And there's a very specific evolutionary reason for that map. It's not a coincidence that this map overlaps almost perfectly with the historical map of malaria endemicity.
It's the same story we see with sickle cell and G6PD deficiency. It is a textbook case of evolutionary pressure from malaria, specifically Plasmodium falciparum.
So being a carrier of a thalassemia gene.
So having the trait, yes, it offers a degree of resistance to severe malaria infection. The exact mechanism is debated, but it likely involves the rapid clearance of infected red cells and reduced parasite replication. But the outcome is clear. Survival.
So over thousands of years, those genes were selected for in populations living in those tropical belts. It was an advantage.
It was a huge advantage. But, and this is why we're doing this deep dive today, that map is changing. Or rather, the map is static, but the people are moving. Migration patterns over the last few decades have radically altered the epidemiology of this disease. It has introduced these pathologies to Northern Europe and North America in really significant numbers.
It's no longer a disease you only read about in textbooks regarding tropical medicine.
Not at all. If you are practicing hospital medicine in London, Toronto, New York, or even smaller cities in the Midwest, you are going to see this.
That is the key shift. This is now a Main Street diagnosis. We are seeing patients presenting with microcytic anemia in the emergency department or complications of iron overload in the cardiac unit, and the differential needs to be broad.
And the burden on these patients is just immense. We are talking about chronic anemia, the complications of iron overload, and the very complex management of lifelong treatment. It is a multi-system disease.
So our goal today is to really break down the genetics and pathophysiology so that we can understand not just how to diagnose it, but how to anticipate and manage these complications when these patients arrive on our wards. Let's start at the foundation. To understand what goes wrong, we need to visualize what goes right in a healthy red blood cell. We need to talk about the structure of hemoglobin.
Okay, so standard adult hemoglobin is a tetramer. Think of it as a structure built of 4 protein blocks, or chains.
4 subunits.
Yes, you have 2 alpha-like chains and 2 beta-like chains. This pairing, this 2 and 2 structure, is non-negotiable for stability and function.
And that specific combination, 2 alpha, 2 beta, makes up the vast majority of our blood.
Correct. That is hemoglobin A, or HbA. The chemical formula is written as alpha-beta-2-2. In a healthy adult, that constitutes about 97% of your total hemoglobin. It is the absolute workhorse of oxygen delivery.
But it's not the only player in town. When we order a hemoglobin electrophoresis, we see other bands, other types of hemoglobin.
We do. There are minor components that are perfectly normal. There's hemoglobin A2, which is 2 alpha chains and 2 delta chains, so alpha-delta-2-2. It usually makes up about 2 to 3% of the total.
And that one, A2, is going to be really important later for diagnosis.
It is a critical diagnostic marker, yes. And then there is fetal hemoglobin, HbF, which is 2 alpha chains and 2 gamma chains, so alpha-gamma-2-2. In adults, it's usually less than 1%.
That distinction between the chains alpha, beta, gamma, delta is so crucial because the body doesn't produce them all at the same time or at the same rates throughout life. There is a programmed switch.
The globin switch. This is one of the most fascinating developmental transitions in human biology. It's an elegant solution to a very specific problem.
And that problem is how the fetus gets oxygen.
Exactly. In utero, the fetus has to steal oxygen from the mother's blood across the placenta. If the fetus had the exact same hemoglobin as the mother, the oxygen transfer would be really inefficient. There'd be no gradient.
So the fetus needs a hemoglobin with a higher affinity, a stronger magnet for oxygen.
Precisely. That is fetal hemoglobin. The gamma chains in HbF give the molecule a higher oxygen affinity than the mother's beta-containing hemoglobin A. So before birth, gamma globin production is high, and beta globin production is very, very low.
But once the baby is born and breathing air, that high affinity becomes a liability. You need to release oxygen to the tissues effectively.
Right. A magnet that's too strong is useless for delivery. So after birth, the production of gamma globin drops off precipitously, and the production of beta globin ramps up. This transition is usually complete by about 6 months of age.
And this timing is clinically diagnostic. It explains so much. It explains why a baby with severe beta-thalassemia, where they can't make beta chains, doesn't look sick in the nursery.
At birth, they are still relying on their fetal hemoglobin, which uses gamma chains. They don't need beta chains yet, so they're completely protected.
They have a grace period.
A grace period of about 6 months. But as that switch happens, as the gamma shuts off and the body attempts to turn on the defective beta genes, the deficiency is unmasked. They become symptomatic, often severely so, usually between 6 and 12 months of life.
You mentioned some specific transcription factors involved in this switch in our pre-show notes. This isn't just academic trivia. Understanding this regulation is actually the basis for some of the newest therapies.
Yes, BCL11A and K11A, for instance, is a transcription factor that essentially acts as the brake on gamma globin production after birth. It's the molecule responsible for silencing the gamma genes.
So if you could take your foot off that brake.
If you can inhibit BCL11A, you can reawaken the production of fetal hemoglobin in adults.
Which would be a functional cure.
It would be. Since fetal hemoglobin works perfectly well to carry oxygen, this can essentially cure the anemia in beta-thalassemia. And that is exactly what some of the new gene editing therapies are designed to do. But in the natural course of the disease, BCL11A does its job, shuts down gamma, and leaves the patient with no functional beta to take its place.
It's incredible how that basic science is translating directly to the clinic. So we have these chains. Let's look at the blueprints. Where do these genes live? Because the location and, more importantly, the number of copies explain why alpha and beta thalassemia behave so differently.
This is probably the most important concept for understanding the genetics in the different clinical pictures. The alpha globin genes are located on chromosome 16. The beta globin genes are on a different chromosome, chromosome 11.
Okay, chromosome 16 for alpha, chromosome 11 for beta. But the budget, the number of gene copies we get from our parents, is different.
It is critically different. For the alpha globin genes, we have 2 of them, on each copy of chromosome 16.
2 genes side by side.
Yes. So, since we have 2 copies of chromosome 16, one from mom and one from dad, that means a normal individual has a total of 4 functional alpha alleles.
4 slots for alpha. That gives you a lot of redundancy, a lot of wiggle room.
It does. It allows for a graded severity. You can lose 1, 2, 3, or all 4. You get a very different clinical picture with each step.
And for beta?
For beta, it's simpler. There's only 1 gene on each chromosome 11, so you only have 2 functional beta alleles in total.
That math 4 versus 2 dictates the entire complexity of the disease.
It dictates the phenotype completely. With 4 alpha genes, you get this wide spectrum of disease. With beta, having only 2 genes, the classification is a bit more binary. You have it or you don't. Though, as we will discuss, the type of mutation matters a great deal.
So let's move to the mechanism of damage. We define thalassemia as a lack of production. But the damage isn't just because the red blood cell is empty. It's so much messier than that.
Much, much messier. If the problem were just empty cells, we would call it simple anemia, and it would be much easier to treat. The disease isn't just about what is missing, it is about what's left behind. It is a problem of chain imbalance.
I want to use an analogy here to make sure this lands with everyone listening. Imagine a factory that makes bicycles. You need 1 frame and 2 wheels to make a functioning bike. Let's say the frame is the alpha chain and the wheels are the beta chains.
That's a good way to look at it.
In data thalassemia, the wheel supplier goes on strike. So you stop making complete bikes. That's the anemia. But the frame supplier is still delivering frames at the normal rate.
Right.
So now the factory floor is just piling up with thousands of useless bicycle frames. They are clogging the aisles, creaching the workers, and destroying the factory from the inside.
That is exactly what happens inside the red cell precursor, the erythroblast. In beta-thalassemia, you aren't making beta chains. But your 4 alpha chain genes are chugging along, producing a normal amount of alpha chains. So you have all these excess unpaired alpha chains floating around.
And they don't just sit there quietly like bicycle frames. They're chemically reactive.
Exactly. Free alpha chains are incredibly unstable. They precipitate inside the red blood cell precursors. They form these aggregates, these inclusions, that generate reactive oxygen species, or ROS. This causes massive oxidative stress. It damages the cell membrane. It damages the DNA. It literally destroys the cell from the inside out.
So in beta-sol, it's the excess alpha that does the damage. What about in alpha-thal? Is it the same story in reverse?
It's a similar story, but with a slight twist. In alpha-thal, you are missing alpha chains, so you have an excess of beta chains. These excess beta chains are a little more stable than free alpha chains, and they can actually form tetramers of their own.
So they pair up with each other.
They do. You get a molecule made of 4 beta chains, which we call hemoglobin H, or beta-42. These are also unstable, but they behave slightly differently. They tend to precipitate in older circulating red cells rather than in the precursors in the marrow.
So the damage happens more in the periphery.
Correct. They still damage the mature red blood cells, which leads to their premature destruction or hemolysis, mostly in the spleen. So you still have damage, but the location of the primary damage is a bit different.
This leads us directly to the concept of ineffective erythropoiesis. I feel like this term gets thrown around a lot in the literature, but what does it actually look like in the bone marrow?
It is a tragedy of the bone marrow. The marrow is trying desperately to compensate for the anemia. The body is hypoxic, so it's screaming for more red blood cells. The marrow responds by churning out precursors, or erythroblasts.
It's working overtime.
It's in hyperdrive. But because of that precipitation of unpaired chains we just talked about, those toxic bicycle frames crushing the workers, those precursors are toxic to themselves. They undergo apoptosis-programmed cell death right there in the marrow.
So they die before they even get a chance to be released into the blood.
Exactly. In severe thalassemia, up to 70 or 80% of the erythroid precursors die within the marrow. It is a massive, futile waste of energy and resources. The marrow is working overtime to produce almost nothing.
And the body just sees the anemia, so the kidneys respond.
The kidneys see the anemia and the hypoxia, and they pump out huge amounts of erythropoietin.
And the erythropoietin levels just skyrocket.
They do, and this just drives the marrow to expand even more. It is a vicious, positive feedback loop. The marrow expands so aggressively that it starts to remodel and distort the bone structure itself.
Which explains the skeletal deformities we see in untreated patients.
Exactly. This is the direct mechanism behind frontal bossing, maxillary hypertrophy, the classic chipmunk facies that's described in textbooks. The marrow is literally pushing the bone outward to make more room for this failed production line.
And it doesn't stop at the bones.
No, the body gets so desperate it starts trying to make blood in other places. You get extramedullary hematopoiesis. The liver and the spleen enlarge massively as they revert to their fetal function of making blood cells, which leads to hepatosplenomegaly.
And this can be dangerous in itself.
It can be. You can even get paraspinal tumors of hematopoietic tissue that can compress the spinal cord and cause neurologic deficits.
And for the few red blood cells that actually survive the marrow and get into the circulation, their life is short.
Very short. That is the hemolysis component of the disease. These cells that escape the marrow have damaged membranes and contain precipitated hemoglobin. The spleen's job is to remove abnormal cells, so it recognizes them immediately and destroys them.
So you have the marrow failing to produce cells.
That's the ineffective erythropoiesis.
And then the spleen is destroying the few that do make it out.
That's the hemolysis. It is a war on two fronts, both leading to severe anemia.
Now, we have to talk about iron, because this is so central to the long-term morbidity. Even if a patient never receives a single blood transfusion, they can still get dangerously iron overloaded. That was a surprising fact for me when I first reviewed this. I always assumed iron overload was just from the blood bags.
That is a very common misconception, and it is a dangerous one for clinicians to have. We call this the double hit of iron overload.
Okay, what are the two hits?
The first hit is the one everyone knows, transfusional iron. A single unit of packed red cells contains about 200 to 250 milligrams of iron, and the human body has no physiological way to excrete that excess iron. We're like an iron lobster trap. It gets in, but it can't get out.
Right. We can regulate absorption, but not excretion.
Precisely. So every transfusion adds to the total body iron burden. But the second hit is metabolic, and it happens even without a single transfusion.
This is the really insidious part.
It is. That ineffective erythropoiesis we just discussed, that massively expanding, desperate marrow, it secretes signaling molecules. One of the key putative signals is a hormone called erythropoiesis. This signal travels to the liver and suppresses another hormone called hepcidin.
And hepcidin is the master gatekeeper for iron absorption in the gut.
Correct. When hepcidin levels are high, it blocks iron absorption from the diet. When hepcidin is low, the gates are wide open. In severe thalassemia, the desperate marrow suppresses hepcidin to near zero levels.
So the gut just absorbs iron completely unchecked.
Unchecked, regardless of whether the body actually needs it or is already overloaded with it. So in thalassemia intermediate patients who aren't getting regular transfusions, they still accumulate a dangerous amount of iron over years because their gut is hyperabsorbing it, all driven by that signal from the failing marrow.
That is a crucial point for long-term management. So that's the shared pathophysiology. Now let's dive deep into the specifics, starting with α-thalassemia. You mentioned this is usually a deletion problem.
Yes. While there are some point mutations that can cause it, the vast majority of α-thalassemia cases worldwide are caused by large deletions of one or more of the alpha-globin genes on chromosome 16, HbA1, and HbA2.
And you said HbA2 is the heavy lifter.
It is. The HbA2 gene produces about 2 to 3 times more protein than the HbA1 gene. So if your deletion takes out an HbA2 gene, the clinical impact is more severe than deleting just an HbA1 gene. The location of the deletion matters.
Let's walk through the classification based on that 4-gene budget we have. We start with losing just one gene.
Sure. If you have one gene deleted, your genotype is written as alpha alpha alpha. You are a silent carrier.
And clinically, what does that mean?
It means nothing for you. You are asymptomatic. Your labs are effectively normal, maybe a borderline low MCV, but often completely within the normal range. You would not know you had this unless you underwent genetic testing.
Is there any clinical relevance at all to being a silent carrier?
For the individual, no. But for genetic counseling and reproduction, yes. If you happen to partner with someone who has, say, a 2-gene deletion, your children are at risk for more severe disease.
So it matters for the next generation. Now, moving on to 2 genes deleted, this is α-thalassemia treat.
Right. And here, the geography and genetics intersect in a really important way. You can lose 2 genes in 2 different configurations.
Okay.
You can lose 1 gene from each chromosome. We call that a transconfiguration. The genotype is written to alpha-alpha. Or you can lose both genes from the same chromosome. We call that a cis configuration, written as alpha-alpha.
So in trans, the deletions are on opposite chromosomes. In cis, they're on the same chromosome. Why does that distinction matter so much clinically?
It matters entirely for the risk to the offspring. The trans deletion is very common in populations of African descent. If a person with a trans deletion has a child, they can only pass on a chromosome that has a single deletion, alpha-this alpha. They cannot pass on a chromosome that is completely blank.
So the risk of having a severely affected child is basically zero if their partner is normal.
Exactly. The risk is capped. However, the cis deletion is very common in populations from Southeast Asia. If you have the cis deletion, you have one chromosome that is completely blank for alpha globin.
I see where this is going.
If two parents who both carry that cis trait have a child, there is a 25% chance that the child inherits the blank chromosome from mom and the blank chromosome from dad. That results in a genotype of $, 0 alpha genes.
Which is incompatible with life.
That is hydrops fatalis, the most severe form. We'll get to that. But practically, this is why identifying cis versus trans is so vital for genetic counseling, and knowing the patient's ethnic background helps you predict that risk.
Clinically, though, for the person with α-thalassemia trait, regardless of cis or trans, how do they present?
Mild microcytic anemia. The MCV will be low, maybe in the 60s or 70s, but they're usually completely asymptomatic. These are the patients who get flagged for a low MCV on a routine physical, get put on iron supplements, and of course the anemia never gets better.
Moving down the severity scale, 3 genes deleted.
This is hemoglobin H disease. The genotype is alpha. You only have one functional alpha gene left. This causes a massive imbalance between alpha and beta chain production.
And those excess beta chains form the tetramers we mentioned.
Exactly. They form hemoglobin H or beta-4-sat-2. This is where we see real symptoms.
So this is no longer just a lab finding.
No, this is a clinically significant disease. These patients have a moderate to severe hemolytic anemia. They have jaundice, they have hepatosplenomegaly because the spleen is working overtime chewing up those HBH-containing cells. They have bony changes.
What about transfusions?
Their transfusion needs are variable. Some can manage without regular transfusions, but others may need them periodically, especially during times of stress like an infection or pregnancy. It is often termed a form of thalassemia intermedia, clinically.
And finally, the most severe form, 4 genes deleted, the empty factory.
This is hydrops fatalis. The genotype is $. No alpha chains are produced at all. In fetal life, the fetus can only make gamma chains. Without any alpha chains to pair with, the gamma chains form tetramers of their own.
A gamma-4 molecule.
Yes, which is called hemoglobin Barts, or gamma-4-2.
And the problem with hemoglobin Barts goes back to that oxygen affinity we discussed.
It loves oxygen far too much. It has an extremely high oxygen affinity. It binds oxygen from the placenta and simply refuses to release it to the fetal tissues. It is functionally useless for oxygen delivery.
So the tissues are starving of oxygen despite the blood being full of it.
Precisely. This leads to severe tissue hypoxia, heart failure, which causes the massive edema, the hydrops, and usually results in intrauterine death or death shortly after birth.
A devastating outcome.
It is, although I should note, with modern advances like in utero transfusions, some of these infants are now surviving, but they require lifelong intensive care from birth and are candidates for an eventual stem cell transplant.
That's the alpha spectrum. Let's pivot now to chromosome 11 and beta-thalassemia. The genetics are different here.
Very different. Beta-thalassemia is rarely caused by a deletion. It is almost always caused by a point mutation, a single nucleotide substitution in the beta-globin gene.
And there are hundreds of these different mutations.
Over 350 have been identified. But for clinical purposes, we group them functionally. We have beta-Scolarti beta-0 mutations, which lead to a complete absence of beta-globin production from that allele. And we have beta-plus mutations, where there is reduced but still detectable production.
And we classify these clinically into minor, intermediate, and major. Let's start with beta-thalassemia minor, also known as the trait.
This is the heterozygote. One good beta gene, one bad one. They have a mild microcytic anemia. It's very similar to alpha-thalassemia trait.
But there is a diagnostic pearl here that helps distinguish them.
Yes, the one we alluded to earlier. They typically have an elevated hemoglobin A2 level on electrophoresis.
Right. Explain that mechanism again. Why does A2 go up in beta-thal but not alpha-thal?
Okay, so remember, HbA2 is made of 2 alpha and 2 delta chains. In beta-thalassemia, you can't make beta chains efficiently, but you have a normal supply of alpha chains. The alpha chains are looking for a partner. Since there isn't enough beta to go around, they have a higher chance of pairing up with the available delta chains.
So the body just sort of shunts the alpha chains toward the delta pathway.
It's a relative increase. The body may even slightly upregulate delta chain production to compensate. The end result is that on electrophoresis, you see an HbA2 level greater than 3.5%. That is the diagnostic hallmark of beta-thalassemia trait.
Then we have the middle child, beta-thalassemia intermedia.
This is more of a clinical description than a strict genetic one, but it's a very useful category. These patients are usually homozygous or compound heterozygous for mild mutations, maybe 2 beta plus alleles, for example.
So they make some beta globin, but not enough.
Exactly. They have a moderate anemia with a hemoglobin usually somewhere between 7 and 10 grams per deciliter. They're generally transfusion independent, but they exist in a fragile balance.
They might need blood during physiological stress like pregnancy or a severe infection.
Correct. And as we noted earlier, these are the patients at highest risk for that silent iron overload from gut hyperabsorption. Because they aren't getting regular transfusions, nobody may be watching their ferritin as closely. They can present in their 30s or 40s with new-onset liver cirrhosis or a cardiac arrhythmia, having never had a transfusion in their life.
A real clinical pitfall. And finally, beta-thalassemia major. This is also known as Cooley anemia.
Yes. These patients are usually homozygous for severe mutations. 2 beta-dular alleles or maybe 1 beta-dulars and 1 severe beta plus dulars. The bottom line is they produce little to no functional HbA.
And the presentation timeline goes right back to that globin switch we talked about.
No, maps perfectly onto it. They are born looking completely fine. But as their HbF levels naturally drop in the first year of life, they crash. They develop profound, life-threatening anemia and failure to thrive.
So without treatment,
without lifelong transfusion support, they develop those severe skeletal abnormalities we discussed and usually die in childhood.
Yeah.
With transfusion support, they can survive into adulthood, but then they face the lifelong battle against the complications of iron overload.
It is not always straightforward alpha or beta, though. We have these important compound forms. The outline highlights HBE beta thalassemia specifically. Why is this one singled out for attention?
It is absolutely crucial because of the demographics. Hemoglobin E is another type of hemoglobinopathy, a structural variant that is extremely common in Southeast Asia, parts of Thailand, Cambodia, Laos. The HBE mutation is interesting. It's a structural variant, but the mutated gene is also transcribed at a reduced rate, so it acts like a mild beta plus allele.
So if you inherit one HBE gene from one parent and one beta thalassemia gene from the other parent,
you have HBE beta thalassemia. And the clinical phenotype is incredibly variable. It can look like a mild thalassemia intermedia, or it can be just as severe as transfusion-dependent thalassemia major. It actually accounts for about 50% of all severe beta thalassemia major cases worldwide, just due to the huge population density in those regions.
So it's a major global health issue.
A massive one.
And then there is sickle beta thalassemia.
This is a co-inheritance of the sickle cell mutation on one chromosome 11 and a beta thalassemia mutation on the other. The severity here depends entirely on the type of beta mutation.
So if it's a beta 0 mutation,
if you have sickle beta 0 thalassemia, you make no normal beta globin at all. The only adult hemoglobin you can make is hemoglobin S. So clinically, it is identical to homozygous sickle cell anemia or SS disease.
And if it's a beta plus?
If it's sickle beta plus thalassemia, you can make some normal HbA. This HbA gets incorporated into the red cells, and it actually interferes with the polymerization of the sickle hemoglobin. So these patients have a much milder clinical course than SS disease.
We have touched on the mechanisms throughout, but I really want to walk through the clinical manifestations system by system. Because when these patients hit the hospital wards, they usually don't present saying, my globin chains are imbalanced. They present with heart failure, or a pathologic fracture, or new-onset diabetes.
That's a great way to frame it. Let's start with the skeleton and growth. We mentioned the chipmunk facies, that maxillary prominence and frontal bossing. But it affects the long bones, too. The marrow expansion thins the cortex of the bone,
making it weak.
Very weak. These patients, especially in the intermediate and major categories, often have profound osteoporosis and are very prone to pathological fractures.
So a young patient presenting with a low-impact fracture needs a second look, a deeper dive into their CBC.
Absolutely. And in children, growth retardation is common, driven by the chronic anemia, the hypoxia, and the massive energy expenditure of that ineffective marrow.
Endocrine dysfunction. This is almost entirely an iron story, isn't it?
It is. The body deposits excess iron in the endocrine glands. It damages the pituitary, leading to hypogonadism. Delayed puberty is often the very first sign of significant iron toxicity in a growing child.
So if you have a teenager with thalassemia who hasn't started puberty, check the iron status.
Immediately. It also hits the pancreas, damaging the beta cells.
Leading to diabetes mellitus.
Yes, but it's often a difficult, brittle diabetes to manage. It also damages the thyroid and parathyroid glands, causing hypothyroidism and hypoparathyroidism, which can present with issues like hypocalcemia.
Let's talk about cardiac complications. This is the leading cause of death in these patients.
Unfortunately, yes.
Yeah.
The primary issue is iron overload cardiomyopathy. The iron deposits directly in the myocytes, causing fibrosis and pump failure. It is typically a dilated cardiomyopathy, but can also be restrictive.
So they present with heart failure.
They do, but arrhythmias are also very common and can be fatal, even before the pump function is severely depressed. This is why we use cardiac MRI with T2 star mapping to non-invasively quantify the amount of iron in the heart muscle and guide chelation therapy.
Hepatic issues. Again, iron must be the main culprit.
Again, it's iron. Progressive fibrosis leading to cirrhosis and its complications. But there is another issue in the liver. Because of the chronic hemolysis, there's a very high turnover of bilirubin.
So they're at risk for gallstones.
Very high risk. These patients frequently get pigment gallstones or cholelithiasis. A young patient presenting with biliary colic or cholecystitis who has a history of anemia should make you think about a chronic hemolytic process like thalassemia.
And finally, a complication I hadn't fully appreciated until digging into the literature, thrombotic risk.
Yes, this is an often overlooked but serious problem. Thalassemia is a hypercoagulable state.
Why is that?
The mechanism is multifactorial. The abnormal red blood cell membranes are prothrombotic. They can activate platelets and the coagulation cascade. There's also evidence of endothelial dysfunction.
And does splenectomy make it worse?
It makes it much worse. Patients who have had a splenectomy are at particularly high risk because the spleen is no longer there to filter out these abnormal red cells and other prothrombotic cellular debris. We see deep vein thrombosis, DVT, pulmonary embolisms, PE, and even portal vein thrombosis in this population.
Let's transition to the workup. You are the hospitalist. A patient comes into the ED. The CBC shows a hemoglobin of 10 and an MCV of 65. How do you distinguish thalassemia trait from the much more common iron deficiency anemia, IDA?
The CBC itself gives you the first major clue. Both are microcytic and hyperchromic. However, in iron deficiency, the bone marrow lacks the raw ingredients to make cells, so the red blood cell, or RBC count, is low.
The factory has slowed down production completely.
Right. But in thalassemia trait, the marrow is working overtime, trying to compensate. It's churning out lots of very tiny cells. So you typically see a disproportionately high RBC count despite a very low MCV.
That's a great clinical pearl. A high RBC count with a low MCV points you toward thalassemia. A low RBC count with a low MCV points you toward iron deficiency.
Correct. There is a calculation called the Menser index, where you divide the MCV by the RBC count. If that index is less than 13, it suggests thalassemia. If it's greater than 13, it suggests iron deficiency. It's a useful screen.
But the definitive diagnosis comes from hemoglobin analysis.
Yes. Hemoglobin electrophoresis, or high-performance liquid chromatography, HPLC. This will give you the quantitative breakdown of the different hemoglobin types.
Walk us through the classic patterns again.
Okay. For beta-thalassemia trait, the key finding is a high HbA2, greater than 3.5%. For beta-thalassemia major, you'll see mostly HbF, sometimes 90% or more, a variable HbA2, and little to no HbA.
And what about alpha-thalassemia?
This is the tricky one. In adults with alpha-thalassemia trait, the electrophoresis is often completely normal. They don't have an elevated A2. HbH, if present, is unstable and hard to catch on a routine test.
So for alpha, if you suspect it based on the CBC with a low MCV and high RBC count, and their ethnicity fits, and the iron studies are normal, and the electrophoresis is normal, what do you do then?
You have to send the genetic test. Molecular analysis for alpha-globin gene deletions. You cannot rule out alpha-thalassemia trait with a normal electrophoresis. And it's important not to just dismiss it as unexplained anemia.
This has been a really comprehensive tour. Let's try to bring it all back together now.
I think if we summarize, we are dealing with two main categories. You have alpha-thalassemia, which is driven by gene deletions on chromosome 16, affecting that 4-gene budget.
Resulting in a spectrum from silent carrier to the fatal hydrops fatalis.
And then you have beta-thalassemia, which is driven by point mutations on chromosome 11, affecting the 2-gene budget.
And the core pathology for both is that imbalance of globin chains.
That imbalance leads to ineffective erythropoiesis, the marrow spinning its wheels and destroying itself from the inside, which in turn drives the skeletal changes and the suppression of hepcidin.
Which opens the floodgates for iron absorption.
And that iron overload is the silent killer, whether it comes from transfusions or just insidiously from the gut in non-transfused patients.
We usually end with a final provocative thought. What stands out to you as the single most important takeaway for our listeners who are practicing in the hospital today?
For me, it comes back to the changing epidemiology. We can no longer view this as a disease of somewhere else. Migration has brought thalassemia to every major hospital system in North America and Europe. But beyond that, I want listeners to reevaluate their differential for microcytic anemia.
To look past iron deficiency.
Exactly. We are so conditioned to reflexively check a ferritin and start iron. But if you see a patient with microcytosis who isn't responding to iron or who has that disproportionately high RBC count, stop. Think about thalassemia.
And why is making that diagnosis in a mild trait carrier so important?
Because genetic counseling for these patients is critical. Identifying a carrier of beta-thal trait, or especially that cis deletion for alpha-thal, could prevent the birth of a child with a devastating severe case of thalassemia major or hydrops fatalis in the next generation. We have a responsibility to catch this.
Absolutely. It's about widening our diagnostic aperture and recognizing the changing face of our global patient population. That brings us to the end of this deep dive. Thank you for listening.
Thank you.
This has been Hospital Medicine Unplugged. We'll see you next time.